So good evening everyone. At the onset, I thank all of you, all my dear friends who are listening to me at 5 o'clock on Sunday, a busy Sunday. Thank you for being here to listen this difficult and boring topic. Although you might find it a bit boring, but then it is very, very important, and in the next 10 minutes, I will prove you that. So, I have been allotted to speak on biology of diabetic foot. So, diabetic foot, although it seems that probably it may not be that important, but I will tell you how it is going to be very, very important in the times to come. This is my favorite slide, which we have seen many times. This is the slide from ICMR in-depth study in which they have published the figures of diabetes, pre-diabetes, dysglycemia, which Dr. Sunil Gupta was speaking about, hypertension, generalized obesity, abdominal obesity, hypercholesterolemia, and high LDL cholesterol. Now the fact of the matter is, you must be aware that almost 90% of the diabetic patient, as in India, are still untreated with the conventional therapy. And most of them, of those who are even treated, only 7% of them are actually achieving the treatment target. And you must be aware, even when you achieve the recommended target, there remains a residual risk. तो 93% जो ट्रीटमेंट पे हैं वो टारगेट पे नहीं है और लगभग 90% कन्वेंशनल ट्रीटमेंट पे नहीं है. And this is the logic. I am expecting a huge surge in the complications, chronic complications of diabetes. Now they can be macrovascular complication, they can be microvascular complication. So macrovascular complication, you are aware, cardiovascular disease, cerebrovascular disease, peripheral arterial disease, and what I am going to speak today is diabetic foot, which is a combo of them. So foot ulceration is common in diabetic patient with a lifetime risk of 19 to 34%, increasing with the age and the medical complexity. Risk factors might include a neuropathy, peripheral arterial disease, visual impairment, nephropathy, poor glycemic control, and the smoking. And you will agree with me that majority of them exist in our common patient. So diabetes and its complications are rapidly becoming the world's most significant cause of morbidity and mortality. And recently only, a very reputed international journal, Nature, has published a data जिसने कहा है कि इंडिया की डायबिटीज की ट्रीटमेंट की कॉस्ट जो है, it's going to be 132 times the defense budget of India. You can imagine that. 132 गुना डिफेंस बजट से डायबिटीज को ट्रीट करने की कॉस्ट है यदि हम सब लोगों को ट्रीट करने पे जाएं तो you can imagine what sort of complexity we are going to face. So diabetic foot is characterized by classical triad of neuropathy, ischemia, and infection. The reported prevalence of diabetic peripheral neuropathy ranges from 16 to 66% as we lack some valid data. And 15 to 20% of diabetic foot ulcer, if left untreated, will ultimately need amputation. So I may bring to your attention that even today, almost around 2 lakh people, 2 लाख लोग हर साल अपने पैरों से हाथ धो रहे हैं और वो अंग भंग की पोजीशन में जा रहे हैं. And we, as a member of Indian Podiatric Association under the leadership of Dr. Masan, we are pledging to prevent amputation, and for that we are here with you. So multifaceted etiology including neuropathy, vasculopathy, and also contributing to that is immunopathy, mechanical stress, and neuroarthropathy. Pathways for ulceration might involve a loss of sensation in the beginning, ischemia, and minor trauma, and that might ultimately complicate to even to amputation. So this is the altered biomechanics, penetrating trauma or ill-fitting shoes sometimes. Neuropathy, sensory motor or autonomic may contribute to it. Immunopathy, which may be hyperglycemia induced, and angiopathy may be as a consequence of the chronic hyperglycemia, may contribute to beginning of a diabetic foot infection, which when not treated will lead to a very devastating complication of amputation. So you can have a foot at risk. Diabetes में ऐसा पैर जो risk पे है, and you can have person at risk. So we need to focus on this slide. So who may be the person at risk? A person with retinopathy, a person with cardiovascular disease, a person of kidney disease, a person with smoking, weight loss and inactivity. All of them predisposes someone to have a diabetic foot, whereas a foot can be at risk with a prior ulceration because of many social cultural habits, edema or callus. And you can have foot deformities like pes cavus, pes planus, midfoot collapse or deformities of toes and foot, which are very, very common in our setting, which can contribute to the diabetic foot ulcer and may be complicated by the peripheral arterial disease and the peripheral neuropathy. So the need of foot examination is of utmost importance. Diabetic foot, especially neuropathic pain, is preventable. A total of 80% of diabetic foot are neuropathic. It is a silent disease. You can also have an arterial, venous or a mixed ulcer, but then the ulcers related to neuropathy are very, very common. The current screening method of diabetic foot are a haphazard, and often we miss to examine a foot which might be predisposed to have a diabetic foot ulcer. Every diabetic foot begins with a small ulcer, and ulcer care is vital to prevent progression. So it is the prevention, prevention and prevention which is the theme of today's talk. So the examination of foot is very, very important in this. The goal of examination is to identify a normal feet, a feet at risk, presence of significant neuropathy, presence of significant ischemia, presence of foot lesions. All of them can actually signal you. You can take a detailed history including duration of diabetes. More is the duration and more close you are to the diabetic foot. Tingling, numbness which might contribute to a silent trauma, previous foot ulcers or amputation, claudication in the leg, difficulty in walking, use of tobacco or alcoholism can contribute to this. You can have a visual inspection of the, you need to first remove the footwear and inspect the foot. Skin, nails, deformities, callus, corn, ulceration, gait may be inspected. You can have palpation in the form of peripheral pulsation like dorsal pedis, posterior tibial artery, bony prominence, plantar aspect, pitting edema you can see, temperature difference in the feet you can see whether there is some temperature difference, joint mobility, subtalar joint position at rest, heel strike can be seen. You can also examine the footwears. हम लोगों के यहाँ पे footwear कई बार बहुत ही खराब पोजीशन में हम लोग देखते हैं which can actually indicate a bad condition of foot. So examination of the footwear is very important. Insist on removal of shoes and socks. Inspect footwear from all sides. Look for the shoes that are worn out, too small, too narrow, or toe box is too low and have high heels. Inspect socks as well. And you can also look for nail dystrophies, erythema, prominent veins, callus, foot ulcers, interdigital mycosis, swelling foot, etc. Foot deformities like claw toe, hammer toe, bunion, gross deformity of midfoot can actually contribute to a predisposition of diabetic foot. And they can look like this. This is the hammer toe, where you can see the digits are looking like a hammer. The pressure is put like a hammer. These are the bunion. Interdigital mycosis, very, very common. Callus, paronychia, they are the very, very common lesion which we can commonly see. Change in sensation can be appreciated. The patient might tell about it. The ulcer examination is a very vast topic. Because of shortage of time, we cannot go in detail of that. But the ulcer, diabetic foot ulcer must be assessed meticulously in terms of site, size, periphery, depth, content and adjacent skin environment. Being a diabetologist, physician or endocrinologist, थोड़ी बहुत सर्जरी हम लोगों को याद करनी पड़ेगी. लव एंड वैली जो हम लोगों ने फाइनल ईयर में पढ़ी है उसको भूलना नहीं है और ये अल्सर्स को हम लोगों को इस तरीके से एग्जामिन करना है. This is the Wagner's grading system wherein you can have a grade 0 with the intact skin which may harbor a foot at risk. Grade 1 may be superficial diabetic ulcer which may be localized. Grade 2 may be a deep ulcer. An extension might involve ligament, tendon, joint capsule and no abscess or osteomyelitis. Grade 2 will not have osteomyelitis, whereas grade 3 will a deep ulcer with abscess or osteomyelitis. Grade 4 may be a limited gangrene and grade 5 may be an extensive gangrene with the entire foot. Often हम लोग जैसे गैंग्रीन होता तो हम लोग भूल जाते हैं कि हमें क्या करना, सर्जन के पास भेजना, लेकिन maybe this may be prevented. So these are the photographs wherein grade 0, superficial ulceration grade 1, deep ulcer like this which penetrate to the tendon bone, grade 3 osteomyelitis involving the bone, grade 4 limited localized gangrene, and this is the grade 5. And you can have neurological examination with a simple test like tuning fork test, monofilament test, ankle reflex, pinprick, biostachiometry. I will not go in detail of that. You can have a MET test. A portion looking darker at some particular places might actually reflect a high pressure, detecting arch of the foot or charcot foot. This is the normal foot. Dark places indicate points of increased plantar pressure, which might contribute or predispose a foot to have ulcer. Smaller surface of areas more in the vertical pressure, henceforth the predisposition of diabetic foot ulcer. You can have a vascular assessment with the help of a handheld Doppler. You can go for ankle brachial index. You can have basic laboratory investigation to assess the glycemia, infection, and the systemic parameters. You can categorize them on the basis of risk. You can have a category 0 risk, category 1, category 2, a very high risk foot. You can decide which category to be examined at what interval of time. You can have early warning signs. ऐसे कौन से फुट हैं जो आपको पहले से वार्निंग देते हैं कि वहां पे डायबिटिक फुट अल्सर होने की संभावना है. सो स्वेलिंग ऑफ फुट और एंकल, वेरी कोल्ड फीट और लेग जिसमें टेम्परेचर कम है, कलर चेंजेस रेड, ब्लू और ब्लैक डिस्कलरेशन, पेन इन द लेग एट रेस्ट और while walking which might indicate claudication, open sores no matter how small it is, non-healing wounds, ingrown toenails, corn and callus, lack of hair growth on the feet, they are the indicator of early warning signs. So the important thing is the most foot problems are preventable. Diabetes being the most common cause of amputation, non-traumatic amputation, this is the most preventable thing which you can do. So most foot problems are preventable through early identification and prompt treatment by skilled healthcare clinician. And the first skill is to remain informed. First skill is to remain aware. Henceforth, I thank all of you for this. So the preventive strategy might involve emphasis on glycemic control, smoking cessation, regular foot care, education, implement guideline directed multidisciplinary care, early detection and intervention, identify high risk individual through screening tools and regular foot examination. एक लाइन में यदि बोलूं तो सिंपल सी बात कहने का मतलब यह, डायबिटिक आदमी को जितनी बार अपने चेहरे को देखना उतनी बार अपने पैर को देखना, जितनी केयर उसे चेहरे की करनी उतनी ही केयर उसे फुट की करनी है. So educate patient on daily foot inspection, proper footwear and wound management techniques, encourage active participation of patient in the treatment plan, provide resource and support for lifestyle modification and adherence to prevent measures, and the education is the most important tool for that. Enhance public health initiative to raise awareness about diabetic foot ulcer and their prevention. And henceforth, I request you, foster collaboration between healthcare providers and policymakers, community organization to address the systemic barriers to the care. And you need to invest in technology-enabled solution for remote monitoring, telemedicine, and the patient engagement to improve the access and continuity of care. So my take-home message is, most of the diabetic remain at a very high risk of developing diabetic foot ulcer in long run. Neuropathy, ischemia, and impaired healing remains the predominant culprit. Prevention remains the core strategy in the diabetic foot-related amputation. The best thing you can do is to prevent a diabetic foot. Wholehearted efforts and teamwork is the key to the success, and we need to pledge to save the feet for our patient. And we are under a mission 2047, preparing India for battle against diabetes. The tsunami of diabetes which we are going to see in the future, and with lot of uncontrolled patient, majority of our crores of patient uncontrolled, you are likely to see a huge number of complications, and many of them will have a diabetic foot. And our organization IPA, Indian Podiatric Association, जिसका नाम है और जिसका nickname है I Prevent Amputation, and I henceforth invite you for the state conference of IPA under the leadership of Dr. APS Suri and Dr. Umesh Matsan sir in Bandhavgarh on 11th and 12th of April. Thank you very much.
Thank you, sir, for such a nice presentation. It has been a pleasure listening to you. And sir, I would like to add that diabetic foot is basically a crosstalk between neuropathy and immune system. Basically, what happens that damage to the sensory nerve fibers, prevents the release of certain peptides which helps in healing of the foot ulcers. But due to increased inflammation and non-release of these peptides, which include substance P and calcitonin, this ultimately leads to increased inflammation and impaired healing, and ultimately there is also vasculopathy involved. So sir, thank you for such a nice talk.
Thank you, ma'am. I would like to add that there are two more factors involved in this. One of them is lack of awareness and other is the ignorance. Majority of our patients are actually not aware that with the smallest of ulcer like this, they can actually go